This is Dr. Bernstein with this month's Teleseminar on diabetes. Thanks for listening. By the way, our next teleseminar will be on Wednesday, April 27th, 2016. A little reminder that most of the questions that we received this month have already been answered in my book, Diabetes Solution. So you could save yourself a long delay in getting your questions answered if you read the book Diabetes Solution. And a little warning that I give every month, the questions can't possibly give me a full individual history on the person described, so I can't possibly have a good batting record on suggestions. It's only a likely suggestion that I might make to a given individual, and it has a good chance of being wrong, but it will be informative for the population of listeners. So just remember that my answers are not absolutely certain answers, they're just likely answers. First, yes, we have a special subject today which relates to the current wave of literature, TV specials, etc. on fasting. A lot of physicians, psychologists, amateurs, physical trainers are recommending that people fast to lose weight. There are even people recommending that diabetics should fast to make their diabetes better. I've had a little bit of experience in this realm now because some of my patients have tried different fasting regimens. And what we see is variable results. For example, I have one person who cut himself down to 600 calories a day for a month, lost a lot of weight. I think he lost somewhere around 40 pounds, which was a huge amount, but he could only do it for a month and rapidly regained the weight. I had another patient who had the notion that he could cut out lunch and breakfast every other day. And lo and behold, he said he was no longer hungry at dinner time. So he's been doing this now for several months, has lost quite a bit of weight, and is continuing and has no temptation to snack, which is what he had been doing before, nor overeat. So for this fellow, this form of fasting has worked. I imagine that different forms of fasting will work for different people, and no form of fasting may work for some people. That is, some people may be immune to benefiting from fasting. There's one little catch when it comes to diabetes. If you are intervening in your routine, you're going to have to change your medication doses. And there's the possibility, especially if you're taking insulin, that you might develop hypoglycemia if you cut out too much food or don't reduce your medications. So it becomes tricky if you have diabetes. If you've read my book, Diabetes Solution, you've become more of a professional at adjusting medications, and therefore you may be able to successfully fast in some manner without getting into trouble. But you have to use your head and know what you're doing. First question: why do you prefer yellow peppers over orange, red, and green? Well, if I have a preference, It's minor, probably born of the fact that when I wrote my first book, which was around 1980, I used the nutrition tables written by Bose and Church. Now it's Pennington and Church. In fact, I think there's even a more advanced version with another new author. And in Bose and Church, yellow peppers had less carbohydrate than peppers of other colors. I don't think it makes a big difference. My 4-year-old was diagnosed 3 weeks ago with type 1 diabetes and celiac disease 12 months ago. I've put her on a low-carb diet and have been keeping her in a range between 50 and 108 milligrams per deciliter. They want to let me give her Levemir, and am I doing any danger by not giving her Levemir and just staying on the diet? Well, that's a good question. One danger with Levemir insulin in a very small patient is that it's not dilutable as the old Ultralenti was, which was an even longer acting insulin, and we could dilute it for children. Levemir cannot be diluted, so there's the uncertainty of getting too much of an effect. You can only adjust the dose in 1 unit increments. 1 unit of Levemir may be worth about 60 on my blood sugar, spread over the course of 24 hours, of course. But for someone who weighs, let's say, a fifth of my weight, 1 unit can lower my blood sugar 5 times 60 or 300 over the course of 24 hours if it were 1 unit more than I needed. So there's trouble with adjusting the dose. Therefore, for very small children, we prefer to use NPH insulin, which, while not really long acting, it's intermediate acting, can be diluted, but you would have to give it probably anywhere from 3 to 6 times per day to cover the whole day, because it's really not long acting. I would say probably, as a guess, 4 times a day for a little child, but it would have to be diluted. And one can dilute insulin with diluting fluid provided by the manufacturer, and you could use all kinds of ratios. For example, if you dilute it 1-to-1, 1 part diluting fluid to 1 part insulin, you've cut the potency of the insulin in half. I use regular insulin for correcting elevated blood sugar that I've diluted 9-to-1. So 1 unit only has 1/10 of the effect that the pure insulin would have. And I have some children getting insulin diluted 15-to-1 and even 19-to-1. So it takes some experimentation. It takes my book to show you how to go about, step by step, how to go about diluting. If you don't want to do it yourself, you can get compounding chemists to dilute insulin. But the chances are that this little kid is going to need diluted insulin. The benefit to taking insulin is that you help perpetuate the honeymoon period. You keep more beta cells alive for a longer period of time. And when, in the rare cases where I've been the one to diagnose a new patient, to discover a new diabetic, if I immediately keep their blood sugars absolutely normal I preserve much of their beta cell function. So that makes life much easier down the road. It's much easier to treat someone who's still making insulin. So if you take this child whose blood sugars are going as high as 108, and most children have blood sugars averaging in the 70s, we narrow that a little so that her blood sugar is, let's see, at a high of maybe 80, 82 at this age. We can hopefully preserve some beta cells. So there would be benefit to insulin, but the Levemir might or might not be too potent. You could experiment, but I'd suggest you read my book first, Diabetes Solution. Next question. Why is Levemir the best in your opinion? I didn't say Levemir was the best. There are pros and cons to the various long-acting insulins. The intermediate NPH has the advantage it can be diluted. The main competitor to Levemir is Lantus, and Lantus likewise cannot be diluted, but it also has the potential hazard for predisposing for cancer. In fact, I believe it was Novo who first came up with the formula for Lantus, and then decided not to proceed because it had something like 165 times the affinity for cancer cells, for IGF-1 receptors, I should say, which are found on cancer cells, 165 times the affinity than human insulin had, therefore suggesting a potential risk. And indeed, studies in Europe showed that in some countries they found considerable risk. In other countries that had different modes of record keeping, they may not have had any risk. So there's the big suspicion that Lantus may be associated with increased rates of cancer. Why take that chance when you have something that doesn't have such an association? Also, a number of people have complained that Lantus burned when they injected it. It tends to be acid and may burn a little. That leaves us with several long-acting insulins that are highly potent, a U300, a U500. We don't need such potent insulins, much harder to measure your dose. They're born of the habits of professional diabetes association practitioners to feed people a lot of carbohydrate and use basal insulin not just as a basal insulin but also for covering food. So they give them a lot of carbohydrate, they give them a very super potent insulin and give them huge doses. But they're mechanically smaller doses because they're so concentrated. We don't want those insulins. There's a new insulin, Tresiba, which is a very good possibility because it lasts overnight. And the Lantus and the Levemir for most type 1 patients does not last a full night because of the dawn phenomenon. You have to take it twice a day, and the nighttime dose usually does not last until you get up in the morning. So people tend to wake up with high blood sugars when they take these insulins. Therefore, Tresiba is a real possibility, and I'm using it on many of my patients. "72-year-old with an A1C of 5.6%, type 2, taking metformin. What are your thoughts on fasting 2 days a week and using your diet for 5 days a week to prevent being diagnosed with diabetes and to lose 25 pounds and get rid of belly fat?" Well, if you're being treated with metformin, you're already diagnosed with diabetes. So even if you lose weight and your blood sugars normalize, as soon as you eat a lot of carbohydrate, your blood sugars are going to go up. So you're diabetic. You're not going to make your beta cells come back. By losing body fat, you can reduce your insulin resistance and therefore make the diabetes less severe. So I strongly recommend something like what you're taking. You're probably if you say metformin, you're taking generic metformin, and we find that it's far less potent than the brand name, which is glucophage. And I don't even know who makes metformin. I have no connection with the manufacturer. I don't make anything on your purchasing metformin, but I have found that the brand glucophage, the original, is much more potent than the generics. As far as fasting 2 days a week, that may be helpful. I don't know. It's worth the trial. You heard me speak earlier about fastings being helping some people and not helping other people. So if it works for you, great. And you'd be wise, if it works, to keep doing it indefinitely. Of course, if you lose too much weight, you may have to stop it. Next question. My sugar reading was 90 before bed. In the morning, 9 hours later, it was 153. There is a formula that suggests an insulin dose based on weight. And this person gives me a complicated formula that I never heard of for, I guess, basal insulin, long-acting insulin. And again, I'd recommend that you use my book. My book gives a safe starting formula, which is probably less than what you will need, and advises you to gradually increase the basal insulin until you have normal blood sugars around the clock. And I think what you ought to do is read my book and use all of the methods in there, not just the dietary recommendations. And I also might point out that if your blood sugar is going up overnight, you might want to reduce the amount of carbohydrate at dinner. You might want to reduce the size of your dinner. You might get an RR study to see if you have gastroparesis, because people with gastroparesis tend to have low blood sugars after dinner at night and then empty their meal while they're sleeping and be high in the morning. But it's important that the long-acting be twice a day. And if you're really insulin dependent, I would think that you might need the Tresiba insulin, which lasts longer overnight. I have a unique situation where, because I get intravenous gamma globulin every 3 weeks to stay alive, I have started making insulin on and off at random and have to check my blood sugar every 3 hours during the night. So because I have to be up, let's say at 5 a.m. in the morning, I take my morning shot of insulin at 5 a.m. I use Levemir, and that is working by 8 o'clock, and I don't have the dawn phenomenon as a result. But before I started taking the shot at 5 a.m., I took it at 7 a.m., I would be high every morning. And if I were not getting gamma globulin, I'd probably be taking Tresiba right now. Next question. Medicare does not want to authorize 5 to 6 times a day that I check my blood sugar. So Medicare does not want to authorize frequent blood sugar testing, does not want to pay for strips. And this is something that we run into frequently. That's why we tell Medicare that all our patients take insulin, because that's one of the criteria for giving you frequent blood sugar testing. It's been a major fight to even get 3 one-touch strips per day. Well, right off the bat, you're not using the strips that we recommend, and you're probably not getting accurate results. If you take those 3 strips and do one blood sugar after another, see if they're all the same. They should be if the strips are accurate. That's a separate problem altogether. I'm experimenting with cheaper meters and strips, but they aren't very accurate. How do I get Medicare to authorize the strips I need? Well, first, I would recheck the strips you're using, do like 5 in a row, and see if they give you all the same reading. That will not tell you about their accuracy, but will tell you about their predictability or consistency. And if they're not predictable, they're not going to be accurate. Now, your physician can fill in an exception form for Medicare. You ask your pharmacy to send your physician an exception form. They can also send one to you. You can apply yourself for an exception, or you can have your physician apply for an exception. You have to give good reasons. You have to be creative in your thinking, and the people who review the request have to think that if you don't get accurate strips, your life is in jeopardy. And of course, if you're type 1, that's probably the case. But even if you're type 2, your physician can create the message that your life would be in jeopardy. So it's probably up to your physician to be cooperative. Next question. Type 2, I am intolerant of metformin. Since Actos is currently facing lawsuits for allegedly causing bladder cancer, do you still recommend it? Would you recommend Invokana? Well, first of all, are you really intolerant of metformin? Many physicians don't start metformin properly. First of all, you should start with the brand product, not a generic form. Second, you should start with the long-acting, the XR. There is forthcoming, if not already on the market, an even longer-acting metformin
that is much less likely to cause diarrhea. The big problem with metformin is that some people get diarrhea. And even the long-acting at the start should be taken at the end of the meal so that it would not be irritating to the gastrointestinal tract. And you start with a small dose, and the smallest dose is 500 milligram. So you start with 500 milligram of the slowest acting branded metformin you could get at the end of a meal. And if you do get any discomfort, you still stay on it for at least 3 weeks, because there's a good chance that this discomfort will go away. So I would prefer metformin over all the other agents. The Actos, the fact that there are lawsuits going on is not because there's a lot of bladder cancer occurring, but because there's a package insert warning about several things, including bladder cancer. So the lawyers see the package insert, they try to find people to sue the manufacturer. I've not seen nor heard of a single case. I imagine there may be some, but it's probably extremely rare. Perhaps more common is a higher incidence of bone fractures in both users of Actos and Avandia, and most common is the incidence of fluid retention. So many users of Actos might get swollen legs. The fluid retention will not cause immediate hazards unless you have congestive heart failure, in which case fluid retention can be hazardous. But I don't like seeing patients walking around with swollen legs. It increases the risk for chronic venous insufficiency and perhaps other problems. So there are potential problems, and I will still, however, use Actos and Avandia if I have no other options, usually in an obese person who's severely insulin resistant, and we need help getting the weight off him. As far as Invokana goes, that's a drug that we've discussed before on these teleseminars. It lowers the renal threshold for glucose, so you end up peeing your excess blood sugar away in your urine. However, there are a host of risks associated with that. I have a few people taking it who are so enamored of the success they've had with it blood sugar wise that they don't want to give it up. But I've had other people who've had urinary tract infections, people who have become dehydrated. You see their hematocrit going up. You see them losing sodium and chloride, and therefore developing electrolyte imbalances. So it's necessary to drink a lot of water when you're using the Invokana. So there are problems with Invokana. I don't like to use it, but again, it's a last resort for certain situations. I am a type 1 for 43 years. So this person is a survivor. They rarely last that long. I started a low-carb diet in October 2015. Even when eating very small number of carbs, 5 to 10 grams in a meal, my blood sugar is spiking. I am assuming this is due to liver dumping glucose. Is this a good sign, or am I doing something wrong? Am I burning muscles or fat? Well, this person certainly should read my book.
My guess is that he's taking long-acting insulin once or twice a day and not taking rapid-acting insulin for his meals. And the book gives a whole regimen in detail how to take rapid-acting insulin for meals. And it's not just carbohydrate that raises blood sugar. If you read my book, you'll learn this. Protein will also raise blood sugar, but not as much as carbohydrate. And the mere physical bulk of a product will raise blood sugar. So a type 1 diabetic can eat a handful of pebbles and his blood sugar will go up just from the bulk entering his intestines. This is all covered in the book. Next person says, I'm a type 1 diabetic and have been eating raw vegan for 3.5 years since diagnosis. I started eating meat, eggs, and protein-rich dishes. 24-hour urine test normal, but a spot urine test just above normal. Should I stay on your diet and go back to vegan? Well, first of all, I have to read this person's mind. What was normal? My guess is that he tested his urine for protein or for microalbumin. And protein in the urine or elevated microalbumin are signs of kidney damage. Kidney damage does not occur from eating protein, nor does protein in the urine occur from eating protein. In fact, I had huge amounts of protein in the urine, 4+ every time I used a protein dipstick, which meant a minimum of 1,500 milligrams per day. And when I went to a high protein, low carb diet, the proteinuria over a period of years vanished totally. So I no longer have any protein in the urine. And that was like 40 years ago. I'm now almost 82 and there's no protein in my urine, and I eat a lot of protein. What I would suggest, first of all, is that this person control his blood sugars and make that number one priority. And there's one other warning. If you're using a commercial laboratory to measure the protein in your urine, there's potential for problems. We've had a number of reports from major commercial laboratories, the two biggest in the country, where they will report 0 microalbumin, which is a very sensitive test for microscopic amounts of protein, and then huge amounts of total protein. The combination is impossible. And this happens fairly frequently. So the top labs in the country are making major mistakes in their measurements of protein, either in spot urines or in 24-hour urines. We have inquiries filed with both of them, but they say they can only help me if we advise their top chemists in advance when a specimen gets submitted before it's tested, so that they could sort of walk it through and see what could be happening that's causing the mistakes. Why they're not walking their other specimens through, if this thing is happening fairly routinely, I don't know. But if you're using a commercial lab, you could be getting erroneous results. Next question. How can you keep your blood sugar at 83 all day long while eating a low carbohydrate diet below 30 grams per day? Will any type of food your blood sugar increases? No, with any type of food, your blood sugar increases. You're correct. With any type of food, my blood sugar will increase if I haven't covered it with insulin. So I have to be very careful in the use of insulin and have consistent meals. If I were to be juggling different amounts of food for each every time I ate, the way the ADA recommends, I wouldn't get any consistency. I have to know that this is the meal I eat. I eat this meal every breakfast, and I take the same amount of insulin every breakfast, and I'll get the same results. However, ever since I've been getting gamma globulin, I can't get my old target of 83 all the time, because sometimes I have to shoot a little higher. With gamma globulin, if you read my book, you'll see that people get some recovery of beta cell function at random, so they could go down all of a sudden and unexpectedly, and never know when. So I have to play it safe. So before this teleconference, I checked my blood sugar, and lo and behold, it happened to have been 83 on the nose. But I took a little bit of protein that will be working over the course of this teleconference, over this hour, on the hypothesis that maybe my blood sugar might be slowly going down. Now, what could more likely happen is I might end up a little high at the end of the teleconference because I took the protein, and my blood sugar, and I was not making any insulin. So I'm at a big disadvantage compared to people who don't get gamma globulin. And my patients who get gamma globulin are in the same boat that I am. They have a tougher job. So it's harder for me than it is for you. Therefore, you certainly don't have any excuses not to have really normal blood sugars. I suggest that you read my book, and I remind everybody that 25% of diabetics have common variable immune deficiency, and at least 10% of those have to receive supplemental IV gamma globulin. My doctor has been trying to get my free T4 and free T3 in the middle of the range. Problem is, no matter how high a dose of Synthroid, my free T4 will not rise. Any recommendations? Well, I can think of a number of recommendations. First of all, if your doctor is associated with a hospital or a large medical practice that has their own laboratory and they're checking the free T3 and free T4, the results they're getting may not be accurate. We were using briefly, actually for several patients, results coming from their doctors' hospitals. And you do the same test 3 days in a row and you get 3 different numbers. So you have to use one of the major clinical laboratories in order to get accurate results. And in fact, the 2 top laboratories, I believe, use the same endocrine lab to do their free T3s and free T4s. That's one problem. The next problem has to do with thyroid binding globulin. If thyroid binding globulin levels are elevated in your blood, they could be binding the T4 and the free T4 will not show up. Free T4 is unbound. It's the form that can be active. If it's bound, it's not going to be active. And if your thyroid binding globulin is too high, it could be binding up all this T4. That's another possibility. The most important thing from the point of view of metabolism is the free T3. So I have a few patients who, for one reason or another, including allergy to the dyes in the T4, may not be getting any T4, but are only getting time-release T3, and they do fine with it. So the free T3 is the more important test. Type 1 diabetic experiencing dawn phenomenon, will they always experience it, or can it subside or change to not experiencing it? I see no reason for it to go away unless you were to become non-diabetic. It's usually triggered by the production of growth hormone while you're sleeping. Now, of course, it could be that maybe if you get to be very old, you may make less growth hormone when you're sleeping, and maybe the dawn phenomenon will go down. But I have not seen the dawn phenomenon disappear in any of my patients, and I'm getting on in years, and mine would be there if I did not take insulin at 5 a.m. in the morning. So the dawn phenomenon should be treated. Now, there's also the frequent confusion of the dawn phenomenon with gastroparesis. People who have the delayed emptying of their dinner frequently find low blood sugars after dinner and high blood sugars the next morning. It's not consistent, so they don't get it every single day, but it happens often enough that they might confuse it with the dawn phenomenon. But you could have both also, more common. Next question. 40 years old, athletic female, type 2. I control through eating. No carbs except veggies and some berries. So right off the bat, she's probably eating enough berries to send her blood sugars pretty high. Despite all my efforts, I am constantly tired. My fasting blood sugar, now 97. I have high cortisol levels. Now, I don't know how she knows she has high cortisol levels. Maybe she's been tested. If she has high cortisol levels, she certainly should be worked up. She could have Cushing syndrome. She could have a chronic infection. All kinds of things could be going on. Let's see. And most puzzlingly, cholesterol is perfect and triglycerides are very low. Yet my A1C is higher than it should be at 5.7. How can that be, and what could I do to improve? Well, she's speaking as if cutting some carbohydrate out is absolutely going to normalize her blood sugar, and she's a diabetic. So she certainly should read my book. She may need insulin. Maybe something like metformin would be of value. She certainly should discontinue the berries. She says nothing here about protein. She could be eating huge amounts of veggies that add up to a lot of carbohydrate. We don't know the details of what she's eating, so she should certainly read my book. And if she really does have elevated cortisol, she should get that worked up. And don't expect your blood sugars to magically normalize. We've seen A1Cs come down from 12 to 6, but we haven't seen them just by diet. But to go the rest of the way down to 4.7, they have to take medications, maybe even insulin. Next question. On 30 grams carbs daily, but gained weight. So increase in the amount of insulin when being treated with chelation therapy. How can I get off the cycle? To lose it and decrease insulin, went from 14 to 20 units of insulin on the Omnipod. Well, first of all, you should read my book, Diabetes Solution. It's number one. Number two, the Omnipod does not give accurate blood sugars. It's a guide toward blood sugar emergencies. So it'll give you an alarm if you go too low. It'll sort of it'll likewise give you an alarm if you go above a certain high level that you set. But you should be using an actual accurate blood sugar meter for adjusting your doses of medication and so on. In addition, if you're undergoing chelation therapy, there are many hazards associated with it. The main one is that the practitioners of chelation therapy also like to give huge amounts of supplements. And one of the supplements they give is vitamin C. And vitamin C does a number of potentially dangerous things, including raising blood sugar, but at the same time destroying the enzyme in the blood sugar test strips so that the blood sugars read low. So it will give you high blood sugars but with a low reading. So all of these things should be taken into account, and I suggest that you read my book and follow it very carefully. Next question. Can high cholesterol be a symptom of high blood sugars? And if you take a statin, will your blood sugars also come down? Well, high cholesterol is associated with high blood sugars. It's also associated with low thyroid. But we now know from modern studies that risk of heart attacks is not associated with cholesterol levels. And in fact, at least in older women where the study was done, cholesterol death risk is a U-shaped curve where over a certain value increase risk of death, and under a certain value increases risk of death. So low cholesterol can be dangerous. Although statins are being used to lower LDL, the reason they lower cardiac death risk in some people, in a small percentage of the users, is because they are anti-inflammatory. They lower inflammatory mediators, and that's now believed the reason for their effectiveness. Now it happens that high blood sugars also increase inflammatory mediators, as does abdominal fat. A statin will not lower your blood sugars, but it has been found that statins increase the risk of diabetes by a little over 20%. So statins might raise blood sugar. My sister and I are the only ones to develop type 1. I worry about my children, 16 and 13, developing it. What test should I have done to detect it early in them? Well, there are some tests that you can still do. You can check their A1C, hemoglobin A1C, every year. And if you see a trend going up, you really are getting a warning. They should be on low carbohydrate diets. They should be exercising strenuously. They should be semi-athletic, so to speak, interested in sports or exercising. Of course, A1C can go up just if you eat too much carbohydrate or if you're getting fat. But it certainly is a clue to the risk for diabetes. And I would say that if they start off with A1Cs in the 4s and then go into the 5s, I would treat my kids as if they were diabetic. I'd be very aggressive. That doesn't mean I'll give them insulin, but it means that I'd be aggressive with the diet and the exercise, might even consider metformin or something like that. Then there's testing C-peptide, which is a measure of the amount of insulin you're making, and you can test this fasting, which is probably the best time for consistency, because if you test it after a meal, it depends upon the size and timing of the meal. So you could every year test C-peptide. You could look at the antibodies that have been considered at risk for type 1 diabetes, but there's a catch there, because there are so many antibodies involved, and the antibody picture keeps changing. They keep finding new ones, and newer ones that are more predictive than the older ones, and so on. The classic ones are what are called the antibodies to the GAD protein on the beta cell, and anti-insulin antibodies. So those tests are available commercially, and you could do those once a year. That's about all I could think of. I think that whatever the test results, encouraging low carbohydrate, high protein diets, and muscle building exercise would, in addition to cardiovascular exercise, would be wise. Advise, please, on using Apidra and Humalog interchangeably. Well, they're not identical insulins. They have totally different timing and different potency. The Humalog is more rapid acting than Apidra. The Apidra is more rapid acting than regular. The Humalog is more potent or stronger than Apidra, and the Apidra may be the same or a little bit more potent than the regular. So you're talking about two different insulins. You can't use them interchangeably. By the way, many drug companies, physicians, etc., pretend that all of these analog insulins are equivalent because they don't look at their patients' blood sugars the way I do. I look when I speak on the phone to a patient who lives out of town, and I've worked him up and I'm treating him. He'll give me maybe 2 or 3 weeks of blood sugar data sheets, but there'll be probably over 100 blood sugars on those sheets, and I'll look at them. And so I see an awful lot of blood sugars, and I see the effects of the different insulins. Most doctors don't bother to do that. Next question. Type 2, is it better to take Invokana or insulin? If you take insulin, can you eventually get off of it? I think insulin, if used properly, if you know how to use it, has less potential adverse effects than Invokana. But of course, if you overdose the insulin, you could kill yourself, and it's not likely that you'll do that with the Invokana. So I prefer to put people on insulin rather than Invokana. Have I ever seen a person get off insulin? I've even spoken in my book about the one fellow, I don't know if he's still alive, he might be, who had gained 100 pounds over a period of years from overeating, and was injecting 100 units of insulin a day on his own. In those days, you could get the pharmacist to give you almost any medication without a prescription. And we shared the same pharmacist, and our pharmacist told me that my friend was getting 100 units of insulin a day. I called a friend, and I sent him to a physician who was able to get him to cut carbohydrate and lose weight. He lost the 100 pounds, had to get a whole new wardrobe, and went off the insulin, had normal blood sugars without any medication. Now, that's what he told me. I don't know, I didn't measure his blood sugars, but these were in the early days of blood sugar measuring, when only I and the people whom I gave meters to were measuring their blood sugars. This guy happened to know the chairman of the board of the company that made the 3-pound blood sugar meter that I used. So that's the one case where I may have seen diabetes reverse. Next question. Are meters accurate enough to aim for blood sugars in the 80s? Yes, if you use the meter that we've been using. However, I do point out that maybe once, as of a couple of years ago, once every 20 or 30 tests, I'd get a very high reading out of the blue. So, and that would always be a surprise, so I would retest. Of late, maybe they have better quality control on their strips. I haven't seen any of these very high readings. So my gut feeling is that the meter we're using is very safe. I'm using it not only for myself and trying to keep my blood sugars in the 80s, but I'm trying to keep kids in the 70s. So we don't have any trouble. But most of the meters on the market are grossly inaccurate. And we've reviewed in my book and also on these teleseminars and my videos how to at least check for the reproducibility of a meter. Okay, let's see. Would you please tell me how to use the diastics? Diastics are urine test strips for glucose. We use them to test food for rapid-acting carbohydrate. We take the food, put it in our mouth, chew it, mix it with our saliva. The saliva will break apart the glucose molecules so that they'll react with the diastics. You then spit it on the diastics and wait a minute. If you're worried about table sugar, you have to do it. You cannot put table sugar in a glass of water and dip in the diastics, you have to put the table sugar in your mouth, mix it with your saliva, and spit it on the diastics. Well, we're finished for today. Remember that our next teleseminar is going to be on Wednesday, April 27th at the same time. Thanks so much for listening, and good luck.